Hello everyone, welcome back to my YouTube channel. This is Dr. Aishwarya Gupta. Today I'll discuss respiratory failure, another very important topic and actually tested in the exam. So idea of my video is to put across all the types of respiratory failure in a very crisp manner so that you understand the pathophysiology and easily place the disease when they are asked in the exam. So without any further ado, let's get started. The respiratory failure type 1 and type 2 are the most important ones since they actually have a are manifested in most of the disease. So type 1 is a diffusion issue. By diffusion, I mean that diffusion is a passive process. There's the hypoxemia. Oxygen is not reaching to the blood. So hypoxemia essentially means then the oxygen partial pressure of oxygen in the blood is low. So that means your PaO2 is small a. PaO2 is decreased at the same time. Try to understand and whenever there is a small a, it refers blood, and whenever there is a large a, capital A, sorry, it represents alveoli. So another question, the PaCO2 is normal here since the diffusion capacity of carbon dioxide is much higher, 20 times more than the oxygen. So even in the when there is a slight diffusion defect, the oxygen is not being transferred to the blood, while the carbon dioxide can easily enter. So usually here you do not get, not usually, you will never get what you call hypercapnia here. The PaCO2 will be normal. So essentially, when the one component is decreasing, the A component is decreasing, PaO2 is decreasing. So the difference between the gradient of oxygen concentration in the alveoli and the blood will increase. So there are certain causes which are important in type 1 respiratory failure. There could be severe pneumonia and even pulmonary embolism due to ventilation and perfusion mismatch, ARDS, which I have discussed the diagnostic criteria and initial management. Even fibrosis can cause a defect in diffusion since the thickness will increase. And if you remember the formula, the thickness is inversely proportional to the diffusion capacity. So the diagnostic criteria for ARDS includes acute shortness of breath within 1 week, chest X-ray showing bilateral, infiltration, and there's non-cardiogenic edema, and PaO2 upon FiO2 less than 300 mmHg. You can actually appreciate in the X-ray that there is a bilateral infiltration, diffuse infiltration. All right. And how do you manage? So you have to give low tidal volume ventilation since the compliance of the alveoli is low. If you give high tidal volume ventilation, they will collapse. So you have to give low tidal volume mechanical ventilation. You can also do prone ventilation, and even PEEP is effective. So that's how you manage ARDS. ARDS is a very important topic and actually tested. So it is recommended to solve more questions because it can actually manifest in many cases, and even many abdominal condition also can present with ARDS like acute pancreatitis. So that's why it is tested not directly also. So I'll recommend to solve more questions regarding this. Now coming to type 2 respiratory failure, it is a ventilation issue. There's hypoventilation. So what happens in hypoventilation? I told in ABG also, when there is a hypoventilation, the concentration of PaCO2 will increase. All right. The gradient is normal since there is a hypoventilation. The exchange of oxygen is happening, which is normal. So this is A minus A is normal. That's a very important pickup point here. Don't mess on this one. Now, causes for this can be actually remembered by the mnemonic as COCD. So, C means central causes can be due to, opioid overdose, which will suppress the respiration, and even brainstem injury, and obstructive causes, severe COPD can cause type 2 respiratory failure. Even chest wall issues like hyposcoliosis because the expansion of the lung will reduce. There is hypoventilation and obesity hypoventilation syndrome. Even diaphragm paralysis, like in myasthenia gravis, polio, or GBS, can cause type 2 respiratory failure because the lung expansion won't be happening properly. Management, you have to treat the condition. You can give oxygen therapy, and NIV also can be given. Now, type 3 respiratory failure is also known as perioperative respiratory failure because usually it is associated with condition like so post surgery like thoracic surgery or abdominal surgery. So what is happening there? There's a parenchymal lung defect. So parenchymal lung defect means the PaO2 oxygen is also going down, and even the hypercapnia is present. So all right, both of the things will be present. Usually it is seen in lung atelectasis, and you can actually manage this by early early mobilization of the patient and even what you call incentive spirometry also worked. And you may have seen the cases in the post-op cases in the ward. If you remember this, it was very much happening, and I think most of the hospital it would be done. The surgeon would recommend early mobilization and incentive spirometry to open up the lung, because the patient will be under general anesthesia, so it will have certain weaning effect. For that to reduce early, you have to do these augmentation processes. Now, type 4 respiratory failure is usually manifested in shock due to the hypoperfusion of respiratory muscles, not much required. No, this is a simple algorithm by which you can actually come to the right answer. So first you have to check if there is a hypoxia, and then you have to check PaCO2. If PaCO2 is normal or reduced, all right, and then you check alveolar minus arterial blood oxygen concentration. If it is increased, like I told you, there is no hypercapnia, and then you have type 1, all right. Otherwise, high altitude because CO2 washout. Okay, so PaCO2 is normal or reduced. Now, if there is a hypoventilation, PaCO2 has increased here, then you check A minus A gradient. If it is normal, like I told you in the ventilation defect, it is type 2. If it is increased, it is type C, like in parenchymal lung defect, or type C post-op. Now, it's like try to read this, and I think this will make sense once you gather the pathophysiology, why it is happening, diffusion, ventilation, parenchymal defect. These are important points here. Why PSU2 is normal in diffusion. So if you recollect that, it makes a lot of sense, and easier diagnosis is very very much in your hand. Now coming to ARDS, I told you type 1, all right, ILD due to fibrosis type 1, chronic bronchitis type 2, all right, and emphysema is also type 1. Since there is a diffusion defect, the terminal, alveoli, they enlarge so much and then they eventually break out. So now what is important here is that all of these can actually have hypercapnia. So all of them can progress to type 3 respiratory failure. That means the gradient will increase and hypercapnia will also manifest. That will combine result in type 1 or type 2 respiratory failure, shifting to type 3 respiratory failure, which can happen in all of them. So by this, I sum up this topic. It was a very small topic, and actually, I had less time this week. So I mean, I couldn't prepare any any huge topic. So next week also, will be the same issue, and hopefully, I'll make something which will be usable to you all. So that's it from me for today. I hope you enjoy reading this, and all the best from my side. See you until my next video. Thank you very much.